So I'd like to introduce our next speaker, who's Josephine Exley from the London School of Hygiene and Tropical Medicine. She's a member of PIRU, the Policy Innovation and Evaluation Research Unit, and she's going to speak about topics in health and social care integration, and specifically learning from international experience. So Jo, over to you.
Great, I'll just start sharing.
Thank you.
Okay, hopefully you can all see that. So thanks, Raphael, and thanks for the introduction. That takes care of my first slide. So yeah, good afternoon, I'm Jo, and I sit in the Policy, Innovation and Research and Evaluation Unit at LSHTM. I'm delighted to be presenting our work on meeting the governance challenges of integrated health and social care on behalf of our research team, all of whom are listed on this slide. And Ellen Nolte will be joining for the discussion, so any questions she'll be able to answer those too. So today I'm going to provide a brief background on what we aim to do and some context on the countries and case studies that we explored. So first, that's what I'm going to do. So many countries are introducing more innovative ways of organising and delivering health and social care services to better meet people's increasingly diverse needs. And we know that there are challenges in establishing novel governance arrangements, both within and between the different tiers of the health and social care system. So understanding and addressing these challenges are key for successful collaboration between the various actors involved. So this study explored the governance and accountability arrangements in 3 countries, so in Italy, the Netherlands and Scotland, to look at the factors that influence directly or indirectly more integrated delivery models or systems. And the study coincided with the COVID-19 pandemic. So we also sought to capture how the pandemic was affecting existing governance arrangements. So the study was conducted to inform the ICSs in England and draw learning for them. So I'm not going to talk about those today, but I will instead focus on the 3 selected countries and briefly touch on the findings and then spend a bit more time drawing out the implications and recommendations. So explore governance arrangements in the 3 countries, Scotland, Italy and the Netherlands. And we made this selection based on a number of factors. First, all have experience of innovative approaches to service delivery that seek to bring together different sectors, and in particular health and social care. Second, their national governments have taken different governance approaches to facilitate integration. And finally, they all share commonalities with the English NHS, such as operating a primary care gatekeeping system and offering most health services free at the point of use. The countries represent a spectrum, so from Scotland on the one side, which has fully integrated health and care system, where NHS, health boards and local government have been legally required to pool budgets and jointly plan and commission certain health and social care services since 2014 through the formation of the 31 integration authorities. And while NHS boards themselves are accountable to the Scottish Government, local authorities are accountable to their electorate. So at the other end of the spectrum, we have the Netherlands, which has opted for voluntary arrangements, typically involving different types of providers, with health insurers playing an increasingly central role in facilitating new ways of working. And the accountability arrangements here are determined by the contracting parties. Italy sits somewhere between the 2, with regional governments leading efforts to improve integration through regulatory efforts. And in Italy and the Netherlands, the role of the national government is largely to provide oversight and develop wider regulatory and policy frameworks for the health and social care system. So all 3 countries provide universal and reasonably equitable access to healthcare for their populations, although spending differs. So health expenditure as a percentage of GDP was highest in the UK, and in terms of long-term care, we see that it was highest in the Netherlands, where spending was about twice the per capita of the UK and 4 times that of Italy. In Scotland, health services are delivered through the National Health Service and financed primarily through general taxation. Local authorities provide or purchase almost all social care services with funding from general and local taxation. And those integration authorities I referred to hold an integrated budget for certain health and social care services. In Italy, healthcare is provided through the national health system and funded again, like Scotland, through national and regional taxation. The regions in this case hold the budget, which are allocated to geographically defined local health authorities who are also responsible for the delivery of healthcare. The budget covers healthcare and the health component of social care, and then municipalities have responsibility for social care. Healthcare is financed in the Netherlands through mandatory health insurance and complementary voluntary health insurance, and financing of long-term care is through statutory social insurance, although some social services are also financed through municipal budgets or general taxation. So in this slide, you can see the 10 case study sites that we selected across the 3 different countries. And I'll go into these in a bit more detail over the next 3 slides. But what I wanted to flag here was that the scale and nature of the case studies reflect the different approaches taken to integration across the 3 countries studied. And where I referred to local throughout this presentation, what I'm referring to is the level at which the case study sites have been implemented. So in Scotland, we selected 3 of the 31 integration authorities, and these have been implemented regionally and cover a population of between 120,000 in East Ayrshire through to 320,000 in the Highlands. And all regions across Scotland, except the Highlands, have chosen to create a new body known as an Integrated Joint Board, and this is made up of representatives from both the NHS and local authorities. The Integrated Joint Board are delegated responsibility for many of the strategic planning functions from the NHS and local authorities. The Highlands has instead divided those functions between the NHS and local authorities, so they've chosen the lead agency model. And some of the services that have been delegated to these boards are highlighted in the slide. And as I previously mentioned, the IJBs have implemented pool budget for those services that have been delegated to them. So in the highly decentralised Italian health system, many regions have undertaken reforms in response to resource constraints and the National Financial Accountability Framework. And our case studies that we've selected illustrate a range of efforts that these 3 different regions have taken. All of them involve regulatory interventions, are planned and implemented at the regional level, and include both health and social care providers as well as the regional governments. So Azienda Zero in Veneto is a newly formed regional body tasked with overseeing the management, financing and quality of health and social care across the region. The chronic care scheme in Lombardy and the houses of health in Emilia-Romagna are examples of integrated care approaches that are implemented locally by those local health authorities. And the Italian case studies are larger than those in Scotland, so they range from 330,000 of the 3 million eligible for the chronic care scheme in Lombardy, all the way through to 4.9 million in Veneto. So finally, the Netherlands. And here our case studies are typically bottom-up voluntary arrangements involving legally binding contracts between the purchaser, so the health insurers, and the service providers. So for example, the Rotterdam Stroke Service, which is the second one listed, is an integrated stroke service formed by 17 healthcare organisations that work together to organise care for stroke patients during the acute, rehabilitation and chronic phase of care. And it's also currently piloting a bundled payment scheme across these 4 different care settings that aims to cover the entire package of care, rather than what happens at present, whereby each provider would negotiate its own contract with the health insurer. So as I mentioned earlier, health insurers are playing an increasingly central role in facilitating new ways of working. And this is predominantly through using innovative forms of contracting. And one of our case studies that we looked at, so the Sustainable Coalitions, is an example where they're using long-term collaborations between the health insurer and service providers to develop innovative care approaches for defined populations. And the aim is to shift from negotiating yearly contracts on price and volume to longer-term contracts of up to 10 years. And unlike in Scotland and Italy, the Dutch case study sites are not implemented within clearly defined regions. They range in size from a relatively small number of patients going through the Rotterdam Stroke Service all the way through to over 10 million patients who are covered by the insurance company that's involved in the sustainability coalitions. So within each of these case study sites, we conducted a number of interviews. We also conducted several interviews at the national level, and these took place between January 2021 and April 22. So over the final section of this talk, I'm going to very briefly pull out the headline findings before discussing some of the implications. So we identified 7 key themes that were reported to have helped or hindered local integration efforts. I'm going to discuss some of these themes in more detail, but want to pull out 2 that I won't come back to. So first, that within case study sites, local leadership was identified as critical to building a common vision across participating organisations, driving engagement and advancing the integration agenda. Absent or changing leadership was seen to negatively affect morale, perceptions of success, and potentially even care. So second, we had an expectation when we started this work that COVID would have a big impact, but we actually found that the pandemic highlighted and exacerbated existing strengths and weaknesses within and across the health and social care sector in all three countries, but that actually it wasn't seen to have led to any novel approaches to how things done. Although in Italy and Scotland, it has accelerated the implementation of policies that were already underway in some form already. So these themes are not clear-cut, and there's considerable overlap between them. And you'll see that now as I start to draw out some of the implications stemming from the remaining themes. Excuse me. So first, for local integration efforts to be successful, there's a need for a unified and consistent long-term vision across the system from the national all the way down to the local level. And there was agreement among participants across all of the countries that there was a disconnect between what the national government aspires to achieve in terms of its wider conceptualization of health and care integration, and actually its own efforts to implement this vision. And so what we saw was a siloed approach in national policies, and it was reported to be very commonplace. Participants gave lots of examples of different directives and mandates having been issued by different government departments and programs, and often these were contradictory of each other. And so this lack of integration and consistency at the national level was seen to undermine integration efforts locally. And real challenges were said to occur where, for example, it's resulted in blurred lines of accountability and misaligned incentives between the various actors, particularly once you get down to that provider level. So to pull out an example, so in Scotland, while the 2014 Act was seen to provide a unified national vision, it was also seen to have created a complex governance landscape and a lack of clarity and accountability arrangements. And participants reported issues of circularity between the different local actors, whereby the integrated joint boards are accountable to both health boards and local authorities and vice versa. So as this quote highlights, this creates an odd situation where on the one hand, you tell me what to do, and then on the other, wow, you're doing what I tell you to do. A degree of circularity of roles and responsibility we also observed in the Netherlands. And so one of the participants from the largest health insurer highlighted that their role was both in engaging in collaboration with providers to develop new ways of working, but also having to hold them to holding them to account and being responsible for holding them to account. Our findings point to the need for a tailored approach that provides an enabling environment and creates a level playing field for those implementing integrated systems. So local experimentation requires sufficient time to bed in, opportunities to test, adapt, change models, make modifications. Time is also needed to foster meaningful and trusting relationships between partners and enabling organisations and services to learn to function in new ways. And this was deemed really important given that new ways of working were not always reported to result in immediate benefits. Some participants pointed to the need that these kind of vision and these change processes need to transcend electoral cycles to provide greater clarity over longer timescales. And those having to implement policies reported being frustrated by national government's lack of insight into local realities And in part, this was linked to blind spots in current monitoring systems. And so in all settings, participants reported indicators were skewed to acute medical care, and that measures to capture broader aims of integration were lacking. So this quote by one of our Dutch respondents highlights, cross-domain multidisciplinary collaboration really needs to look at different monitoring mechanisms. You've created a kind of make-believe world if you look at that one small set of indicators, that one care provider who performed that one action. While acknowledging the need for performance monitoring, in all settings, respondents wanted greater emphasis placed on the quality of care and patient experience. So moving now to the economic context, this was seen as highly challenging for realising the service transformation agenda. Prolonged periods of austerity, the focus on cost control and efficiency savings were seen as the main driver and accelerator of national integrated care policies in all settings. So this quote from the Scottish interviewee highlights how challenging it was to start these IJBs. So the potential for creativity was denied at birth, and the constant necessity of making efficiency savings at a time of rising demand was doomed to fail. The desire for achieving cost savings and the use of targets were reported to play a key role in monitoring and evaluation. So examples in the Netherlands, where they highlighted there were real challenges of estimating cost savings when actually the impacts are intended to be realised across the entire health and care system. In both Scotland and Italy, there were examples cited that poor financial performance was a key reason and an overriding factor for regional initiatives to be brought under national government management. Supporting new ways of working is therefore likely to actually require additional resources. Finally, in all settings, the fragmentation of financing was seen as especially challenging, and the acute care sector was seen to dominate over social care in terms of resource allocation. Attempts to redirect more resources towards social care was widely seen as insufficient. So in the Netherlands, this was reported to be a result of the lack of integrated funding between health and social care. In part to try and overcome some of this, the Netherlands is currently experimenting with longer term commitments to integration using these multi-year contracts that I mentioned earlier. And these are intended to provide more certainty, allow for greater flexibility locally. So it'll be interesting to see how these unfold. In Scotland, fragmentation of financing should in theory not present the same challenges, given that the 2014 legislation introduced these pooled budgets. However, what we found was that there was a perception that in practice that hadn't really been a reality, and that the integration authorities have been unable to break that connection between the funding source and the allocation. So as the quote says, there's a sort of pooling of budgets and then the IJB puts it back in the same place. The failure across countries to truly pool budgets was seen to prevent more collaborative decision-making about service planning and delivery, meaning integration is likely to only continue to occur at the edges. So just finally to touch on two limitations. So this study focused on the commonalities across case studies, and it sought to capture a wide range of case study sites in each country. So we relied on a relatively small number of interviews in each case study site, and what we would really like to do is to fully capture the governance complexities and the interrelationship with the national level, to have spoken to a larger number of people and additional types of data collection such as observations. And second, we did have some challenges as a result of COVID, which posed challenges to recruitment, both in terms of our ability to speak to key individuals and also the timing of the interviews that we were able to conduct. Thank you very much.
Thank you, Jo, for such a clear and interesting and presentation, such an important topic. So thank you. And we've now got, I think, a good 10 minutes now for questions. So can I welcome any questions, please? I'm not quite sure if I can see everybody at once. Yeah, I think I can see. So any questions, or shall I start with the question? You mentioned both perverse incentives and you mentioned also sort of fragmentation around funding and financing. I think it's fair to say that social care has really been dogged over the years and in different countries by perverse incentive issues. And I was wondering if you'd like to say any more about that, or any examples you particularly came across of sort of perverse incentives and sort of difficulties over the financing arrangements.
In terms of perverse incentives, I'm not quite sure if I meant, but I could just, on the financing side, I think there was, across all sites, there's just this real perception that acute care has continued to dominate. And it was clear to see that in countries like the Netherlands, where there is a clear distinction between health and social care, and that has really limited what they've been able to do. So they've been able to bring in, through the reforms of their funding system, they've been able to bring in the more health components of social care. And we see that integration, so taking that stroke service as an example, it goes as far as the kind of chronic care, but then the activities of daily living have not been integrated into that because of this differentiation between the health insurance and the social insurance. So it places real limits on what they can do. But even in Scotland, I'm repeating what I said, maybe Ellen wants to come in and add something additional, but even in Scotland, they haven't been able to break that funding, that it seems that healthcare still dominates. So yeah, I'll pass to Ellen if she had anything to add.
Yeah, if I may, just a quick addition to that, Raphael. I think what was really interesting is that this sort of dominance of the acute sector was reflected in the indicators by which all these organizations are being assessed. So there's this kind of positive feedback loop. We have very good data within the NHS, for example, or within the healthcare service. And, we know, perhaps understand better patient flow. And there was very little good data on acute care, but because we have better data in the healthcare sector, so that tends to be where the resources get sucked in. And then, of course, the other issue is certainly, well, actually in all three countries, there are different agendas which have to be crucially due to the accountability relationships. Of course, the healthcare providers are still accountable to the healthcare agencies, whereas the social care or the long-term care element is usually overseen by a local government, and they have different, they have the electorate to respond to, and this creates this constant challenge and tension between towards better collaboration.
Thank you very much for explaining that. Thank you. Jose Luis, I think you have a question.
Thank you, Rafael, and thank you, Josephine, for a very interesting presentation. I was so I was struck by the point you made about COVID-19, how it affected. So that wasn't that surprising, but I think you said that it exacerbated some of the tensions between health and social care partners. My experience in England, talking to, for example, directors of and people involved in the health and social care system, is that at one point, at least, it sort of brought them together because there was this common challenge and so the things like sharing of information became easier. And why do you think that was different?
So we definitely observed that in the data. So we had a lot of examples of people sort of talking about how much it's given them greater appreciation for the need for working more closely. And so there was definite acknowledgement of the need for integration care, why it's important. And in Scotland, for example, I think it's sort of moved off the agenda. So lots of things that they were hoping would stay in place transferred, potentially because of then the pressure post-COVID with waiting lists and other pressures that have built up. And I think Netherlands potentially offers some quite interesting lessons, given its more networked approach and its ability, it seemed, to respond very quickly because it maybe to do with size, relatively small networked approach, good communication between the different individuals involved within those case study sites, that they knew each other quite well. They could draw on personal relationships to activate quite quickly some of the changes in ways of working. But ultimately, this hasn't led to any major changes. And then,
yeah, can I just add to that? I think it was observed in all three countries, that red tape was cut, it was much easier to do things, and there was a sort of expectation that this would carry on. But as soon as the crisis phase was over, they just went back to the olden days, the old way. So it wasn't really sustainable. And I think what really important what we found is that across all three countries, there was a perception that the global crisis from 2007-8 actually had a bigger impact on transformation than COVID had, because a lot of stuff that countries wanted to implement were already on the train. The only thing that COVID potentially did accelerate certain things that were already underway. And this, you can see that in the new policy documents that have been issued. So there was no fundamental change because of COVID. It just made some things happen quicker in terms of system transformation than perhaps otherwise would have been the case.
Thank you. Are there any other questions? I think we've got time for at least one more question. Just trying to see whether anyone else is indicating they'd like to ask a question. Gerald. Sorry, you're on mute.
Apologies for that. Thank you, Raphael. And thank you very much for the presentation, which was fascinating. I wanted to ask a question about the dominance of the acute sector, which, you know, as you say, you found to be an issue in all three systems, and that would be the case, I'm sure, of many other systems that weren't in the study. What I'm wondering is whether you found any indications of how, you know, at all in the three countries, of different strategies for trying to shift the power balance between the acute sector and, should we say, the long-term care sector. And if you know, could offer any sort of potential areas in which we might focus future research or development ideas, or do we have to accept that the acute sector is actually ungovernable?
Ellen might draw on another example, but I think the Netherlands is again quite an interesting example where they're trying to move to these kind of network approach, and by coming together to and then also with these moving away from these individual provider contracts with the insurer to trying to put value across the care provided across the entire network, and it's sort of shifting the focus from an individual level focus of what do I need to do to meet my requirements to what do I need to do with my colleagues for us to meet this requirement. I think they still see some issues with cherry picking, with some organisations being unwilling to take patients earlier and things like that. But I think that could offer some quite interesting learning over time, that move to a more kind of treating it as a network and how we can measure. But speaking to the health insurance, it's for them, it's then how do you cost that? How do you then assign value to that? So that's one of the challenges that they've got going on at the moment. Ellen, I don't know if you had another example.
No, I think that the Netherlands is probably the best example. I think in Italy, one of the key challenges is that investment in social care is low anyways. And the acute care sector is always seen also as a major election. Trump, oh, that's probably not the right word, actually. Major election, yeah, whatever the right term is, but it has always has a long time been one of the key issues on which national and local elections are being decided on. And I think that unless that shift is happening also at the local local authority side, that that we have to rebalance that, and there's some real commitment to invest more in social care. I think it's going to take a while. Having said that, Italy is one of the beneficiaries of the EU, what's it called, recovery.
The COVID recovery
fund, which is unfortunately the UK is no longer able to dip into, but Italy is receiving quite a substantial amount of funding from that fund to rebuild its primary care structure across the country. And they've really invested a lot, interestingly, also in community hospitals to move away from the acute sector, I suppose, dominance to really kind of move more into care closer to people's homes and the related infrastructure that is required to deliver that. I haven't quite answered your question, but there is some movement going on in Italy, which is, I think, very interesting to observe in the next few years.
Thank you very much.
Thank you very much.